It's really our honor to have Dr. Walker with us, and Toba Niazi is going to have the honor of introducing Dr. Walker in a moment. I just wanted to say a couple words about Sanjeev Bhatia, for whom this lectureship is named. Sanjeev was a resident and fellow here with us at the University of Miami, and was an integral part of our program. He passed away 4 years ago. A life in neurosurgery cut way too short. We were honored to be able to work with him. It's been our privilege to name this lectureship in his honor. And for those who don't know him, please ask us. We're happy to share all kinds of Sanjeev stories with you. I think he's sincerely missed. And without further ado, I'm going to turn it over to Toba so she can introduce Dr. Walker. And Jack, thank you so much for being with us today.
Thank you, Dr. Raghib. Thank you, Dr. Walker. So it's really an honor and a privilege to introduce Dr. Walker today. Thank you for spending the morning with us at 5 a.m. your time to honor our dear colleague and friend, Dr. Bhatia. So Dr. Marion, or those of us that trained with him, know him as Jack Walker, was born in Columbia, Mississippi. And I asked him one day, why is he called Jack? And he said in third grade, he decided he was sick of being called Mary. So he told his parents he wanted to be called Jack. So every time somebody called the office and said they wanted to speak to Marion Walker because they were a good friend, we all knew that wasn't true. So he attended Brigham Young University from 1960 to 61, and then he served an LDS mission in California and Arizona. He then returned to BYU after his mission and moved back to Mississippi, where he then completed his pre-med work, and then went on to graduate from the University of Tennessee College of Medicine in 1969. He completed his residency training in neurosurgery at the Barrow Neurological Institute in 1976. And then he went on to work at Toronto Sick Kids, the Hospital for Sick Children, where he did a fellowship, and he developed a passion for pediatric neurosurgery under the tutelage of the 3 H's. And for those of you who don't know who that is, it's Dr. Bruce Hendrick, Harold Hoffman, and Robin Humphreys. So Dr. Walker then moved to Utah, where he began his neurosurgical practice in Salt Lake City in 1976, where he focused his career on pediatric neurosurgery at Primary Children's Hospital. He joined the faculty of the University of Utah in 1981, where he established the Division of Pediatric Neurosurgery and then the Fellowship Program in Pediatric Neurosurgery. He quickly rose through the academic ranks to become Professor of Neurosurgery and Chief of Pediatric Neurosurgery, and held that position for 28 years. And he made significant contributions to the field, including pioneering the use of selective dorsal rhizotomy for spasticity, the treatment of hydrocephalus, and also the separation of several sets of craniopagus twins. Dr. Walker retired as Professor Emeritus in 2016, and an endowed chair was established in his honor. He was a leader in established pediatric neurosurgery as a recognized subspecialty, and was instrumental in founding the American Board of Pediatric Neurosurgery and the Accreditation Council for Pediatric Neurosurgery Fellowships. During his career, he served every leadership position in the field. But most importantly, and those of us that know Dr. Walker, his wife, Susie Walker, and his 5 children have really served an important role in his career. Dr. Walker has been an inspiration to the next generation of neurosurgeons and has trained scores of pediatric neurosurgeons, and was really the reason why I applied to the University of Utah and ultimately went on to become a neurosurgeon. I'd never really heard of the University of Utah until I met Dr. Walker as a third-year medical student on the East Coast when he was a visiting professor, and fate brought us together where I had an opportunity to go up to him after his talk and ask him some questions. He told me I would be crazy to not apply to the University of Utah if I was interested in neurosurgery, and more importantly, if I was interested in pediatric neurosurgery, as they have one of the busiest programs in the country. The rest is history. Thank you, Dr. Walker, for inspiring me, and thank you for being here this morning.
Well, thank you. Thanks, Toba. Well, that was a very nice introduction, and I appreciate that. It's always a little daunting for a pediatric guy to speak to an adult audience and try to find something that would be of interest to keep your interest for a little while. And believe it or not, I'm hoping to get your interest in the topic of shunt overdrainage. It's looking back on a career. It's something that is so important, and I know that it applies even to our adult colleagues. First, I think let's start off with the definition. Hydrocephalus, hydro meaning shunts, and cephalus meaning many revisions. Perhaps one of the best definitions I've seen of hydrocephalus. But shunt overdrainage is a topic that I feel very passionate about. And looking back over my career, I really wish I felt that same passion when I first started in pediatric neurosurgery. Many of my colleagues don't consider it a big problem. Even within the pediatric neurosurgery groups, I think some just think, let's put a shunt in and not worry about it. Even though the incidence is relatively small, these patients can cause a lot of problems. I'm sure Toba and John are well aware of the problems the overdrainage problems can cause, and they can be a nightmare. And I'm going to try to help you go through my current thinking on this. Let's start off with a case illustration. A 15-year-old male who was shunted in infancy, and he's doing well. He's had no prior shunt malfunctions. He's doing well in school. Everybody's very happy. If you looked at his scan, he has small ventricles, but he has, in essence, adjusted to this intracranial environment. And then one day he starts having headaches, progressive headaches, and a CT scan is done, and it shows the ventricles are enlarged compared to his prior studies. So it's his first shunt revision. And now we can't get it right. A year later, he's had 5 shunt revisions. He's had a shunt infection. His school performance is not what it used to be. He's depressed. Unfortunately, this is the kind of case that shows up because of shunt overdrainage. And we'll talk a little more about that as we go. Now, we don't need to talk, excuse me, a lot about the history, but just know that hydrocephalus has been with us forever. And in the more modern era, it was Walter Dandy who really had a strong interest in hydrocephalus. He published 22 papers related to hydrocephalus, and it was something he cared a lot about. The first shunt valve really was implanted in 1949. It was at the Children's Hospital in Philadelphia. Frank Nelson and Eugene Spitz, they basically put together a non-reflow valve, and they placed it in a young boy, an 18-month-old, excuse me, who had hydrocephalus, and they shunted him into the jugular vein. This child actually experienced a smooth course. His fontanelle remained depressed, but you know what? This was their only success, and they decided that the valve was too difficult to make and was too expensive, so it was impractical. And they just didn't follow up with that. They made a shunt, but they just thought it was impractical to have that kind of thing going forward. It took Holter and his son Casey to make a difference. Holter designed a device. He was told his son had spina bifida and hydrocephalus. He said, "What do you mean there's no treatment for hydrocephalus?" So he helped design the first valve that we know as the Holter valve. It subsequently was bought by Codman. I'm sorry, I keep having in my throat tie up. And the Codman valve was the one that, that basically all of us used in the early part of my career. And it was a very successful one. And about the same time, a group in California was designing a shunt. Ted Heyer and Dr. Bob Pudins got together with Rudy Schulte, who was a shunt maker, a watchmaker, and they designed a burr hole type valve. So, you know, just having a shunt and just surviving is not enough. We try to control our hydrocephalus, but we haven't really tried to cure it. And of course, there are lots of complications when we place a shunt. All of you know the issues of shunt dependency, infection, foreign body reaction. We don't regulate the drainage of CSF, and many patients develop small ventricles. As a result, aside from improved shunt design, ETV and the ETP CPC, there have really been no dramatic advances in hydrocephalus for basically since it started, 70 years. And despite newer shunt designs, overdrainage continues. All shunts overdrain, and every single shunt, some more than others. And it depends a lot on how we manipulate the various shunts that we have. After the first generation, the second generation came along early in the 70s. Over the next 20 years, it developed a differential pressure valves that were adjustable, anti-siphon devices. If you're young, if you're Toba's age, you probably don't remember the original anti-siphon device. It was kind of flimsy, so that scar tissue could press down on it pretty easily. We called it the anti-function device because we would put it in, and often the next day we needed to take it out. Their anti-siphon devices have improved. They're shielded a bit more from the overlying scar tissue. And obviously they're gravitational valves, they're adjustable valves, and there's been attempts at sort of flow control. And since 49, there've been 163 different designs on the market as of 2017. I haven't updated 27. I haven't updated it since then, but it just illustrates the trial that we've been going through to try to find that perfect shunt. The problem is not just the shunt, though. We change the intracranial environment significantly when we place a shunt. And I think that concept is something we need to keep in mind. We lose normal intracranial pulsations. If you think about it, every time your heart beats and you have a patent shunt in place, there's a little tiny bit of squirt where that CSF is passed down the shunt system. It's over time, that tiny little heartbeat keeps going on all the time, and you keep pushing this little micro amount through the shunt. That's the easy way out, is through the shunt. And so it's not surprising that over time we overdrain. It's just a matter of mechanics, that having the shunt in place. So we place the shunt in an infant, and they grow accustomed to the change in this intracranial space. And if you go back to the case illustration I showed in the beginning, that young man did well for 15 years. And he had an intracranial environment that's far different than a normal person. The problem was, when he had his revision, we simply couldn't get it right back to that same environment that he had prior to his shunt malfunction. As a result, as I've pointed out, we overdrain and develop small ventricles, slit ventricles, however you want to call them. The incidence, the only real study that's out there is one that we did back in the early 90s. And we looked at 270 consecutive patients in our practice. And you can see basically two-thirds of them had very small ventricles. About 10% were normal. And it's probably a general representation of most practices. Now think about it. You place a shunt in an infant. The original shunt design trial that Jim Drake and John Kessel published back in, I think it was 96, they looked at new shunt placements in the pediatric population. And if I remember correctly, 90-something% of those new shunt placements were in children less than 1 year of age. So just think about it. You place a shunt in an infant, they have big ventricles, and their brain is doubling in size the first year in life. So this brain is growing, starting to fill the intracranial space, and we're draining the fluid out. So not surprisingly, you lose those normal compensatory mechanisms that we've been talking about, and the ventricles are getting smaller. Now, slit ventricle syndrome is a phenomenon that occurs only in children. Now, my adult colleagues, I know you're standing up and yelling at me, but bear with me for a moment. Adults don't get the slit ventricle syndrome. And if you think about, if you go back to what we were talking about, placing a shunt in a small child and that growing brain and that overdrainage, if you look at the head circumference chart on the right, this child started off with an enlarged head with hydrocephalus, but over time, this child's shunt or head growth is not keeping up with the normal, and it's not that uncommon for long-time shunted patients to develop a head size that's small compared to the normal head growth chart. Now, adults already have their brain fully grown, and so they don't get this same pathophysiology that a child does. There's no question that adults can overdrain and get headaches, and I'm not saying that that doesn't happen. It sure does. But this syndrome of overdrainage and the disproportion, if that's a proper word, between the growing brain and the overdrainage of CSF. We all know it's difficult to treat slit ventricles. We've tried everything: observation, limits, try to limit the drainage. We treat them with anti-migrainous therapy sometimes. Lots of times we have to revise their shunt. There's just a lot of options that we've tried, and nothing has been the perfect solution. And you know, our teaching regarding hydrocephalus doesn't really match our clinical observations all that well. You know, going back to medical school, we're taught that the arachnoid villi are the primary site of CSF absorption. It may be that absorption there is as low as 25%, maybe even lower. We know now there's increasing evidence that CSF is absorbed through the lymphatic channels and through the blood vessels, primarily the veins and the capillaries over the surface of the brain. I think there's a lot of absorption there. Perhaps the intraparenchymal water transport system has something to do with it. The olfactory bulbs in the lymphatic system are increasingly important in our understanding of where CSF is absorbed. Our understanding of this not only is inadequate, and it may be incorrect. Again, we're saying if you have, you have hydrocephalus, a communicating hydrocephalus, it doesn't fit the picture of a dam and the water backing up behind it. If the absorption of CSF is at the arachnoid villi, why isn't the CSF prominent over the surfaces of the brain? And in communicating hydrocephalus, that's not the picture, obviously, that we see. There is one condition that I think is more accurate, and that is the benign extraaxial fluid of infancy is related, I think, to the immature absorption of CSF in some children. And it takes time for them to get up to speed, so to speak, and start absorbing CSF normally. As a result, we see the CSF over the surface of the hemispheres, and almost without exception, that all goes away by 18 months, 2 years of age. It doesn't require treatment from us. And that's a more accurate picture of how it should look if our concept of communicating hydrocephalus were different. I hope that makes some sense to somebody. Now let's talk for a second about pulsatility, because it plays a big part in understanding hydrocephalus. If you look at that graph, we all know that if you increase the ventricular pressure, the pulse pressure goes up. That makes sense, obviously, because you're increasing your intracranial pressure and you're starting to feel that pulse, and it becomes intense. But it's also true that the amplitude increases with decreasing ICP. Anybody who's had a lumbar puncture will tell you how true that is. That low ICP, the amplitude of the pulse also increases. So the bottom line is there's a point here. People have started calling this the notch. There's a point where we live, where we're comfortable. We don't feel that pulsation all the time. We're comfortable. That's where we're used to having it. But on both sides, low pressure, high pressure, we're not comfortable. Joe Madsen and his group at Boston Children's looked at the same idea of pulse pressure, and I think they're the ones that started calling it the notch. That point of between too high and too low, basically where we lived. And they, again, using dogs, showed that you can make the notch disappear by increasing the ICP, but that it slowly comes back over time. Now, how does all this relate to shunt overdrainage? Let's go back to thinking about that original patient that we talked about. How does it relate? This is a band stop. It's an illustration from, if you think about your car radio, you're listening to a station and not having other stations coming in at the same time. you're a certain band and you're listening to it. This notch, this place on the ICP curve where we sit is similar. We're in that notch where we're comfortable. So what happens when we place the shunt? What have we done over time? Have we basically eliminated the notch? Have we just covered it up? Have we moved it to one side or the other? I think in reality, what we've done is we've made that notch so narrow that it's hard to hit that target again. It's like that same young man that we talked about. It's just simply hard to get back there. If you think about that same case illustration, after he had a shunt revision, it's so hard to find that same spot. So far, our treatments have been routinely successful. None of our treatments have been routinely successful. Reversing this is difficult. If you're this 15-year-old young man with slit ventricles, the damage is done, so to speak, and we can't undo it. So we need to somehow think about preventing this from happening. Real beautiful article recently in the Journal of Neurosurgery Pediatrics from Steve Schiff and his colleagues at Penn State. Basically showed that it's not normal, obviously, to develop slit ventricles. There's a normal relationship between brain and CSF volume as you go through life. So how do we prevent this scenario of overdrainage, which we can't really change? I'm sorry, we can't undo. How do we prevent it? If you think about it, you get 80% of your brain by the time you're 2 years of age. What if we were able to control the amount of shunt drainage just in this first 2 years, so that we didn't let the growing brain interfere with the fact that we're draining a little bit too much CSF. We hopefully don't get a chart that looks like the one that we have here. And again, I pointed out that adults don't have this mismatch that children do. So there's one thing we've never tried. You know, there's literature suggesting that programmable shunts are no better than a plain shunt that doesn't have programmability. My only complaint about that is that if you have a programmable shunt and you just place it in and don't do anything, it's just like any other shunt. I mean, if you set it at a medium type pressure, it's a medium pressure shunt. One thing we've never done in terms of studies is looking at, could we take programmable shunts and over time slow down the drainage of the CSF so that when you get to that 2 years of age, you still have some ventricles and you don't have this setup of too small ventricles already starting. I think it would be an interesting study, but nobody has really done that, at least to my knowledge. I tried that in the last few years of my practice, and I can tell you that over that short time, it works. There's no question that programmable shunts overdrain like others, but it's maybe possible to slow down the amount of overdrainage. Well, we all have to think about smart shunts. What are they? I can tell you with my my ties to industry, not just Medtronic, but others, that finally shunt manufacturers are really thinking about how is it possible to make something better, not just the same old, same old. So I believe that a programmable flow control shunt could change many of our problems. If we had a shunt that we could, that was truly a programmable flow control. And in my mind, that would be perhaps a pump, so that you're not draining CSF, you're allowing CSF to drain because you're setting the pump, and the pump is programmable. Now, not all CSF is produced at the same. It's probably produced a little more in the infant. It's produced less in the elderly. So in the perfect smart shunt, you're probably going to need something that is related to measuring ICP and a feedback to the pump that's controlling the flow. But if you could control the flow, in essence, you're not allowing the slit ventricles to develop over time. We're a ways away from that, but I think to me, that's the kind of shunt design that might be the next generation of a smart shunt. So really, hydrocephalus is something that affects all of us, whether you're practicing in the adult world or not. There's no treatment that's the best treatment. I've pointed out to you that shunt overdrainage is not uncommon at all. And my personal belief is that controlling the flow as we go forward is something that's the next step. So thank you very much for your attention. I'm happy to answer questions if there are any.
Thanks, Jack. That was wonderful. Since I invited you, I get to ask the first question. I'm going to point out to my adult colleagues that at the end of that graph you showed of that child several times is age 18, and you've been instrumental in leading us to think about transition of care. So although our adult colleagues may not think it's their problem, these young people will become their problem in the future. And I think that's why this lecture was so important. So thank you for bringing this up. I'm going to ask a two-part question, which I hope you can shed some light on. First off is, you mentioned that there are gaps in our understanding of the physiology of hydrocephalus. And it seems to me that that's the fundamental issue here. And perhaps you could elaborate on, for the benefit of the young residents listening, if you were to have a career in neurosurgery and want to make an impact, where would you focus your attention in understanding the physiology of hydrocephalus, since you know the literature so well and the gaps in knowledge? And then the other is, are we going to solve hydrocephalus with technology and hardware, or is it going to be answering the first question first? So thank you again, Jack, for being here and shedding light on the subject.
I would love to see a time when we're taught from our first exposures in medical school that hydrocephalus that we start teaching based more on the reality of some of the physiology of hydrocephalus, rather than just say it's all absorbed up at the arachnoid villi. It just doesn't make sense that that's the case. So why we're starting out with a simple concept for medical students, when I think it's much more complex to understand. I think if you're starting out as in the pediatric world and you want to understand hydrocephalus, boy, that's a tough question. I think focusing on the the physiology as best we know. I just think if you start the concept of obstructive hydrocephalus, makes a lot of sense. We understand if an obstruction at the level of the aqueduct, we understand that it makes sense that the ventricles dilate. What doesn't make sense is that we're, say, communicating hydrocephalus, the fluid gets out of the ventricular system, and yet we don't see it up over the surface of the hemispheres. In a sense, that is obstructive hydrocephalus also. The fluid's not getting through the subarachnoid spaces. And even though we're calling it communicating, and maybe that's the right word, in essence, it's still a form of obstruction. So understanding some of the pathophysiology from an early time, I think is going to help going forward for some of our young folks to help us redesign our shunts and the way we approach it. Is technology going to solve the problem? I don't know. It's never going to solve the problem. I think the future is going to be related to pharmacology. It's going to be related to genetics. And it's also going to be related, hopefully, less and less to technology as we go forward. Hydrocephalus is not a single gene disease. It's caused by so many different things, but genetically, it's going to genetics is going to play a huge role as we go forward. And for those of you who maybe not aware, there has been a huge focus on research in hydrocephalus over the last 12 to 15 years. The Hydrocephalus Association started out with a commitment to research, and they started giving little small grants, $25,000 grants to young people interested in studying hydrocephalus. And those very young people have grown into very important federally funded researchers. And the Hydrocephalus Association now is accounted for I forget the numbers, but it's like $30 million they've been able to raise or help achieve federal grants. So there's a lot going on in research, which I'm excited about.
Dr. Walker, thank you. This is Toba again. So question for you. I know what your thoughts were, about 12, 13 years ago regarding endoscopic third ventriculostomy. But in the last decade and then some, there's been quite the resurgence with Ben Worf's work and all of the information from the HCRN that's come out. What are your thoughts about ETV-CPC and neonates, both post-hemorrhagic and post-infectious? And do you think that, so two-part question, that's the first question. And then the second question is, in the subset that has been successful in Dr. Worf's and others, and even our trials here in Miami, but do you think that the reason why we've seen some success with it is because of this other channel outside of the arachnoid villi? So I'd just like to hear your take on the ETV-CPC.
Well, the ETV-CPC is a very interesting concept. I think what Ben Worf has shown us for his patients in Africa was wonderful, because in essence, there was no other real option for him And it's been great to be able to treat those children. If we go back and think about the pathophysiology, the worry I have about ETV CPC is the taking away a lot of the choroid plexus. It takes about a 90% reduction to have a successful CPC, ETV CPC. But the production of nutrients that come from the choroid plexus might be very important for the developing brain. Just some of the thyroid hormones that are produced by the choroid plexus are important for brain growth. We're not going to know the answer to this for a long time, but I am concerned that we're taking away some natural nutrients for the brain that might be a problem as we go forward. Using ETV CPC in the population we have in North America is very different than it was in Africa. There is a study from HCRN underway looking at ETV CPC, so I think we're going to get some answers from that. If I had a young patient, a newborn that needed treatment right now, I would probably opt to give that as an option to the families. I'm not against it. I'm just nervous that we don't still understand the long-term benefits compared to shunting. On the other hand, I don't know if it's really true, but I've heard from some people that a lot of the choroid plexus can regrow, or that part that's left can expand. So maybe they're producing those hormones that we're worried about. But if you talk to a neuroscientist, they're worried about what we're doing. If you talk to a neurosurgeon, wow, this is a great way to not have a shunt. So the answer is not totally there yet, but it hopefully will be over the next 10 to 15 years.
Jack, I know why Toba asked that question, because she has to listen to me endlessly say avoiding a shunt is the best shunt. So I appreciate your response. I don't want to monopolize the questions, but since we have an adult audience for us, Jack, it seems to me that a lot of academic departments across the country are developing, for lack of a better term, sort of a hydrocephalus service. The complexities of what you're describing about managing an adult patient, a child who's grown into adulthood with hydrocephalus and a shunt, sometimes is beyond the level of interest or attention from a general neurosurgeon. I'm just curious what you thought about that idea, where you see big departments now develop a person that is the go-to person for treating hydrocephalus in the department. Maybe just give us your thoughts on that subject.
I think it's very important for departments to develop a hydrocephalus service. Obviously, our pediatric colleagues, we vary in our ability to treat patients that are in the transition ages. At my institution, I could hang on to a shunted patient, age 21, age 22, a complicated patient that my adult colleagues really were hoping I wouldn't send to them. But there came a point where I just couldn't have that patient at the children's hospital, especially when the bed situation would get tight, when RSV season would come, the hospital's full, the administration would be telling me, no, your 23-year-old patient needs to be admitted to the adult hospital. Other of my colleagues practice in a situation where there are not a freestanding children's hospital, and it's easier for them to manage that same hydrocephalus patient on the adult side. And there are situations where the hospital says once you turn 18, you have to seek your care elsewhere. So there's a variety of situations out there, but the reality is our adult colleagues are going to keep seeing these patients because they're growing up, they're surviving, and they will be a part of the patient population on the adult world. Our colleagues in private practice are not as likely to be interested in taking care of these patients. And our colleagues that work in a university setting, I think, have an obligation to find a way to help in management of these patients. It's not, they're complicated patients. Let's go back and say that a lot of our graduating or transitioning adult hydrocephalus patients are doing fine. I'm not saying that everyone is in this situation of overdrained and trouble, but there are enough patients that they're okay, but then they have that shunt malfunction once they're on the adult service, and they're still going to show up with, for lack of a better term, you can't get it right again. It's difficult to make that patient comfortable. And we've all heard comments by, even within my service, I'll have a patient I've taken care of for a number of years. They enter this situation where they have a shunt malfunction, and we can't get it perfect again very easily. Well, I took care of that patient, let's say, for 12 years. And now one of my colleagues on call takes care of that patient's revision in the middle of the night. And the family keeps telling me, it was perfect when you did it. Why? I don't want to go to Dr. X for my follow-up because he doesn't know how to do it like you did. Well, we all know the reality of what that situation is, but we see it.
Any thoughts on having neurologists assume the care of hydrocephalus patients?
I'm trying to not say something bad.
That would be wrong.
I want to set you up. You can just take the fifth.
I think our neurologists, with the training that they go through, very, very few of them have any focus on hydrocephalus or, frankly, any interest in hydrocephalus. Hydrocephalus means surgery, and neurologists in our North American environment just think surgery is not a great thing if there's any way to avoid it. So it's not something that the typical neurologist would come to, and most would shy away. Now, there are exceptions to that, and perhaps the most prominent is Mike Williams, who has a hydrocephalus program out at the University of Washington in Seattle. But that's been his lifelong focus is hydrocephalus. So I think the answer is that we're not likely to see neurologists In Europe, it's a different story. Many of the neurologists there are part of the management of the hydrocephalus team. And perhaps it's worth saying that normal pressure hydrocephalus is a totally different disease than what we're talking about with shunted in infancy and being transitioned to the adult population. The normal pressure hydrocephalus is a different patient, and they've already proven, I think, quite well that the programmable shunt is great for this population.
Dr. Walker, Jacques Morcos here. Thank you again for really doing this today. One question and one comment. First, maybe a physiology question. What do you think the tracing of compliance, delta V over delta P, would look like if it was superimposed on that curve you showed with the notch? Do you think compliance will steadily decrease as the ICP goes up, or is that even relevant? I remember as a resident, I did my residency in Minnesota, University of Minnesota. My mentors would always say, "Oh, the shunt of the future will be a shunt that's linked to compliance, not to ICP or flow rate." It's that's my first question. Well, anyway, maybe I'll stop at this and then give you my comment after you answer me. Thank you.
Well, I think perhaps your question is what I was trying to get across with the graph of this. I think this notch where we supposedly are comfortable, where we live, over time, we've made that notch so small that it's difficult to find that happy place again. I mean, that's really compliance that we're talking about. If we took that compliance curve, what we've done is just made it so narrow because of having an abnormal physiology in our brain or in our head for a long time. So I
right.
think that's what's happening. That smart shunt, really, we're all talking about the same thing. We're talking about some way to maintain a more normal intracranial environment. If we make 22 cc's of CSF an hour, then draining 22 cc's that hour is hopefully a way to help maintain normal pulsations, normal compliance, and not relate and not be putting us in a situation where over time we're narrowing that notch where we're supposed to be comfortable.
Okay, great. Thank you. My other comment, I don't know if you're aware, my friend and colleague, the chair at Tufts, Carl Heilman, he does adult neurosurgery. As he says the story, he's been so frustrated, like many people who with shunt revisions and stuff years ago said, I'm going to give it to the endovascular people. So actually the FDA has approved trials. He's come up with a device of going endovascularly up the inferior petrosal sinus and piercing it with a 22 gauge needle, essentially creating a not VA, like a little connection between the CSF in the posterior fossa and the inferior petrosal sinus.
Right.
It remains to be seen whether this will work. They've already done 10 cases in South America, and I'm not sure exactly when they're going to start doing the US cases. But what do you think of that concept? A little tiny tube that would bridge CSF into the inferior petrosal sinus.
Well, I'm very aware of that. I think that's an exciting study that they've started. I guess the first couple of questions that come to mind is if this is a successful treatment, where are we going to find people that can do it? If it's the endovascular guys, there's not nearly enough of them to treat all these patients with hydrocephalus. So it's going to be a little bit of an issue if this turns out to be something that's very exciting. The other question might be what happens when there is malfunction of the system, and
yeah, exactly.
Who then treats that patient? But the study is underway, and I think it's either just started or about to start here in the United States. So it'll be interesting to see what happens with it.
Thank you very much.
Well, Jack, I'll take the opportunity again to thank you for being with us today and honoring the memory of Sanjeev with this lecture. It was really spectacular. It's wonderful to have you with us. For those who don't know, Dr. Walker is going to give a talk tomorrow through Children's Grand Rounds, again online. This is going to be on separating craniopagus twins, a slightly different topic than today, but it might be of interest to the department as a whole. And the link is available through the Nicholas Children's website, or you can contact my office if we can help. So Jack, thank you so much for being here. I know the residents have some case presentations for you, so they'll hang on, and I think Toba's going to be part of that. So look forward to seeing you tomorrow, Jack. Thanks again.
Thank you. My pleasure.
Dr. Walker, do you want to take a minute and take a 2-minute break before the residents start their case presentation? Or are you okay to keep going?
Yeah, I might take a physiology break.
Okay, perfect. All right.
Be right back.
No problem.
Okay, Toba, you got to make them be nice to me.
All right, don't worry, they will be. They will be. These are just a couple of our cases that we've had over the years that the residents wanted to show you, and then also get your opinion about what you would do differently or anything that you would recommend in the future for us to do differently. So go ahead, guys. I don't know who's presenting first.
Hey, Dr. Walker, thanks for joining us. My name is Michael. I'll be presenting some of the cases compiled by the residents, so hopefully it'll be good fodder for discussion. Right. So first case, this is a 34-week-old infant born by IVF. Postnatally was in the ICU for 17 days for a GBS infection. Incident was noted after birth to have a thoracic hemangioma as well as a dimple, and I'll show a picture shortly. And as part of the workup, they did an MRI of the spine as well as an ultrasound. So this is what the child looked like. As you can see, the hemangioma there. And here is shortly after birth, the MRI that was done, showing this lesion, the subcutaneous lesion, as well as concern for lesion in the spinal canal. There was also concern on this MRI for a sinus tract. Moving along, here are the Dopplers of the hemangioma itself. And here's the ultrasound showing the conus terminating at L23. On this image, the thoracic lipoma was seen, but the sinus tract was not appreciated. So the patient was followed up at a month of life. Dermatology was involved and initiated treatment of the hemangioma involving laser therapy and propranolol. The plan was for surgery later in life, around 1 year of age, for the tethered cord. Here is the further follow-up. The patient actually remained neurologically stable. The mother was actually hesitant to proceed with any sort of surgical intervention. So the decision was made to follow the patient closely every few months in clinic. Here's the child at last follow-up, and this was at 2.5 years of age. So you can see this is the lesion, the hemangioma with the obvious dimple. Has completed the treatment of the hemangioma itself with dermatology. Clinically, the patient has done well. No, for mom, no obvious evidence of pain. Legs seem to be moving fine. The child started walking at around 15 months. Seemed to have some sort of physiologic in-toeing when walking, but nothing concerning for the orthopedic service. no urinary issues, no significant urinary issues. And given the stability neurologically, the decision was made to continue watchfully waiting and following up the patient clinically, and to do surgery in the future should the patient develop symptoms. So I'll show you the most updated MRI here. This is the most recent one that we have, showing the thoracic lesion. And this is the T1, here's the T2. So curious your thoughts about how to manage a patient like this with minimal symptoms, but an obvious lesion that we would expect to cause symptoms at this age or soon at least.
So I'll interject here, Mike. Mom has refused surgery, and we've offered her surgery, but I think one of the interesting points here, Dr. Walker, that I'd love your advice and opinion on is, what do you do with these kids with these large hemangiomas? Do you allow the dermatologist to proceed ahead and treat them with laser therapy? Or do you proceed ahead with surgery first if obviously this is a complex patient that has not had surgery because mom is reticent? But what are your thoughts about the hemangioma, the treatment of the hemangioma with laser treatment? And then what do you counsel these patients when they do refuse surgery?
What about before we get into that? You mentioned about he's still potty training at 2.5 years. He has some in-towing. What about his feet? Do his feet look normal? Does he have any high arching or something suggesting there's some little neurological change? The feet sometimes are the things that can guide what you're seeing.
The feet so far do look normal. And that's why I've also sent them to be evaluated by the orthopedic doctors, because mom was concerned about the way that he started walking. But overall, there's no high arch, there's no flat foot, nothing like that going on. But he's also very young so far.
Have you found any specific vessels feeding this lesion, or any significant venous outflow related to this?
No, I have not. It's the dermatologists have finished treating him, and they saw him before we even got our hands on him. So they noted this hemangioma at birth and started treating him with propranolol and then laser therapy at, I think it was 2 or 3 months of age. And then an MRI was done at that time as well. And then he was sent to our office afterwards, after several.
If you had seen this patient first, would you have involved the dermatologist?
I probably would not have.
I don't know what have they accomplished?
They've just made the hemangioma less aggressive looking, I guess, is they like to lighten that hemangioma is what they like to do. Make the family happy. You have the most recent, there you go.
Well, I guess I wouldn't object to having dermatology involved, but I don't see that they're really going to accomplish anything that we're concerned about in terms of the neurological system. I would drag my feet on this guy as much as reasonable. I'm just trying to think how you're going to improve him with surgery. If you can see definite change neurologically, that he's worsening in some way, that obviously would make me start thinking about surgery. But I think surgery is dangerous for this guy, and the older he is, if he's stable, I might just agree with mom and drag my feet for a while.
Okay.
Have you operated on him?
I've not. No, I told mom the same thing. He's clinically doing okay, and he does have the lower lying conus as well. This is a really complex patient, so I told her that I would be happy to see him. She was nervous in general about everything going on with his skin. And so I see him probably about every 6 months to a year. He's only 2.5, so I've seen him a handful of times now. So I'll tell you, I had one case that I'll never forget. It was a kid with a large hemangioma, and it was laser treated, tethered cord. And essentially, the surgery was uneventful, went very well. And the child had kind of like a lipomyelomeningocele, very large, fatty component, very low lying conus, and we detethered her. And then the skin overlying that region fell apart because of the laser treatment, which the dermatologists will tell you they've never seen, and I've never seen it before either. And we had to put wound vacs on her, and it took about 2 months for her to heal. So I'm very reticent about getting these hemangiomas treated prior to intervening on them because of that one bad experience that I've had.
Dr. Walker, how does the presence of the cord signal change here on the MRI change things? In the adult world, we're taught that often alone is an indication to intervene and prevent, worsening in this child, even though he's neurologically doing well. I don't know if that changes management at all.
Well, do you have any, can you compare this over time, or is this like the next MRI after the one in infancy?
It's the next MRI after infancy. And the infant MRI is not the best quality MRI.
Well, again, it just makes me nervous to go in and cause an infarct trying to treat this lesion. I think you're going to have to treat it at some point, but as long as he's stable, and you maybe should get MRIs enough to see if there's progressive change in terms of the signal. But looking at that axial image that you have up makes you think that you got to do something about the cord. So he needs to be followed pretty closely.
Sorry, Toba, did you say that he had urodynamics or no?
Well, he's 2.5, so he's not had any urinary tract infections, and there's no concern for neurogenic bowel or bladder, and he's voiding and stooling well. And the urologist didn't feel that that was necessary because everything looked normal, and urodynamics are pretty difficult to perform on a kid that, when I saw him initially, I think he was 6 months. And as long as there's no evidence of enlarged bladder, they will typically not move forward if there's been no other kind of signs or symptoms in the child.
Yeah, I guess like the question would be if like you follow that serially over time, would that, if there's a change in something like that, that's subtle, that might be something that would lead you to intervention, as opposed to, if there's something, there's a subtle change in the urodynamics. I don't know if that's something you want to get over, like as he gets older and it's a little bit easier to do.
Now, the other thing, Mike, if you can show that dimple, so that dimple extends down and does go through the spinous processes into that thoracic lipoma area as well.
Is his spine, I know he's young, but any evidence of scoliosis, kyphosis, any changes there?
Not yet.
Well, you're going to create that with surgery.
Yeah, absolutely.
Again, letting him get older maybe is good, but you're not going to be able to let him get to 15 years of age. So at some point, it's probably going to need a treatment.
All right, we'll move on to the next case. It's an 18-year-old boy who presented with progressive weakness, predominantly in the left arm. Of note, the patient has Crohn's disease and is on immunosuppressant, Remicade. On exam, subtle upper extremity weakness, 4s to 5s bilaterally. Did have evidence of hyperreflexia with Hoffman in both hands, as well as patellar hyperreflexia. Sensation, did not have any sensory deficits. Here are the images. I'll play these videos for you. This is with contrast. This is the T2. And here's the axial. All right. So the patient was treated with steroids given his stable neurologic exam. The concern was related to the fact that he was on Remicade and the concern for wound healing on the medication. And it was decided that waiting at least 8 weeks after his last dose would be the safest. Patient was discharged with steroids, returned to clinic later, again, neurologically stable. MRI was repeated and also stable. So given the constellation of neurologic stability and radiographic stability, the thought was that this was a ganglioglioma. And so ultimately, once the 8 weeks had passed since the Remicade, the decision was made to take him to the operating room with a plan for biopsy and followed by maximal safe resection of the tumor. The case was a suboccipital craniotomy and a C1 to 5 laminectomy. In the case, midline myelotomy was made, and there was actually a good plane between the tumor and the cord, better than what was expected for a ganglioglioma. The tumor, most of the tumor was removed. There was a bit closer to the cervical medullary junction that during removal led to some bradycardia. And so that was decided that a little bit of tumor would be left at the depth of that resection. And so maximal safe resection was achieved, and the pathology intraoperatively was read as ganglioglioma. Here are the post-op images. Postoperatively, there was a slight decrease in his strength in his upper and lower extremities. The main issue was with his hand intrinsics and some proprioceptive difficulty. However, this has gradually improved. The final pathology returned as ependymoma. Final molecular pathology is pending, but final path was ependymoma, not ganglioglioma. The patient went to rehab, has again progressively improved, is walking independently, and has had increased dexterity in his hands. So pending the molecular pathology, the patient will go for proton beam radiation. I'll go back to these images here.
So I guess I'll add here that this child was offered surgery. However, the mom is very well read, and we put him on steroids. His right upper extremity function improved. It was right before the holidays, and she was also told by the GI doctors that it's the wound healing would be an issue. So she wanted to wait until after the holidays, as long as he was stable. So they were offered surgery initially, but there's, as you know, Dr. Walker, a lot of social issues with these patients and their parents. So that was the rationale for the waiting. And then they also got several other opinions as well to see how to proceed ahead. I guess in this situation, would you go back for that residual amount, or how would you proceed ahead with this?
I think you did a great job with your first surgery. I'm surprised, based on what you were saying, that you found as nice a plane with the surgery. And in retrospect, you would expect a better plane with the ependymoma than you would with the ganglioglioma. I probably wouldn't want to go back, because you achieved what you thought was the safest. And I'm not convinced on the images that if you went back, you would get all of the tumor out. We've all gone back in these situations, and sometimes there is a better plane than you think for that second look. But My gut feeling is you're going to need to give him proton therapy treatment anyway, so I'd probably go that route.
What's been your experience with these spinal ependymomas, Dr. Walker? How successful have you been with treating them in general? We know about the question is this more, did it begin more in the cranium and extend downwards, or did it start more spinal and extend superiorly? I guess that's one of the questions our oncologist had is there going to be a difference in the behavior pattern of this based on cranial versus spinal ependymoma?
Well, my experience has been mostly with the spinal ependymomas, and they have a nice plane and you can get them out, and they're typically pretty benign. Again, based on what the images look like here, I think this started at the medulla and extended downward. That's just the typical appearance of a tumor that starts in the region of the medulla and the lower brainstem. It's hard to say if that's, it's still an ependymoma within the spinal cord, the lower brainstem. I think it's hard to predict the future in terms of its aggressiveness, but you've left tumor behind, and whether it's growing slowly or not, or faster, it's you're going to need to treat it. I don't know that there's a rush. You could let this all calm down and monitor it with MRI for a bit, and it might help you make that decision whether to treat with radiation or to take a second look. Is this a relatively new case?
He was operated on probably about a month ago, correct?
Yeah.
Yeah, he just left rehab, so.
Well, he's improving. Give him some time, see what happens with the imaging. It just looks so diffuse on your post-op images, though, in the medulla region. It's doesn't look very distinct.
That's where we had trouble, and we had bradycardia. So yeah.
There's a lot of trouble there.
Yeah.
All right. Third case. Sure, go ahead.
I wonder if I'm still perplexed about it being an ependymoma based on the imaging. The pathologists are pretty confident that's what it is.
So we sent all of our, we don't have neuropathology like you guys had there. At Children's. So we send everything out for an official read by Ari Perry out in San Francisco. And he's confident it's ependymoma.
Okay.
All right. Our next case, this is a 5-month-old baby transferred from Kuwait, born with this very large mass at the level of the thoracic spine. Here, I'll show you some imaging now. Large mass in the subcutaneous space extending into the intradural space and seemed to be attached to the thoracic spinal cord. Very complex structure, hair, bone, and other tissue. So the concern was for teratoma and an incomplete conjoined twin. So here are the images. Go through them. Again, a complex cystic lesion connected to the thoracic spinal cord there. Go through this one more time.
Yeah. Stop. Go back. Yeah, right there.
There we go. So, and here's some other, these are still images of the sagittal. Is a CT showing the bony extension. So this is a combined case. The general surgery and plastics team were involved in the removal of a lot of the soft tissue mass. Then we were involved for the resection of the interdural component and the mass in the thoracic spine. And duroplasty was performed, and plastics helped with the closure as well. Postoperatively, the MRI showed enlarged subarachnoid spaces and a large ventricular system, and so there was a concern for this collection, the subcutaneous collection at the surgical site. The patient was afebrile. It was presumed that this collection was in fact CSF, and so the patient went to the OR for an endoscopic third ventriculostomy and CPC to avoid a shunt. This was done. That actually the collection was aspirated, and it was found to be frank pus, which grew Klebsiella. So went for a washout and ultimately developed a pseudomeningocele. And so this required a lumbar drain and ultrasound guided aspiration of the collection. Completed antibiotics and in follow-up has had no reaccumulation of the collection. At 1 year, the child is doing well. Everything is well healed. Like I said, no reaccumulation of the fluid collection. Good strength in the upper and lower extremities. Able to stand and walks with assistance. So obviously not perfect in the lowers, but functionally has improved significantly. So I'll go back to the images for the discussion here.
What did you see at that initial surgery in terms of the spinal cord?
I don't know if Dr. Raghib is still on here.
Thanks, Jack. These guys are at a disadvantage because this is a case I did a couple of years ago. So that intraspinal mass was gliotic disorganized nervous tissue, which was attached to the dorsal surface of the spinal cord. And there were roots coming from it that went no place, essentially. And I thought this case was interesting because of the developmental implications, particularly with your experience in conjoined twins and other variations. I'm sure you've seen a bunch of stuff like this, and I'm just wondering about your strategy. One of my regrets is getting plastic surgery and general surgery involved.
Yeah.
I blame them for the persistent subcutaneous infection, the poor handling of the skin, and they're not on the call, so I can pick on them. But anyways, I'll stop. But just interested in your thoughts.
But you were able to find a plane to take this away from the spinal cord.
So what you see on the post-op scan is I left some of that gliotic stuff attached to the dorsal surface of the cord. I was reluctant to take it down because the PIA was conjoined, and I didn't know what.
Yeah. Okay.
Yeah. So I just sort of used the lipoma rule. Take it down to where you think the normal stuff stops and stay away from it.
That had to be, it really wants to be a conjoined twin. I'm not sure there's another good explanation for it, but it tried to be a conjoined spinal cord, it sounds like, with one that was just not functional at all. I think you did the right thing trying to leave a little bit of it attached, because I would be surprised if you find any plane there to just dissect it away, because it basically was conjoined.
We had a similar case of conjoined twins at the sacrum dorsally, and they had a U-shaped spinal cord with roots coming out of the thing, and So I had that case in mind and was doing my best to sort of stay away from it, even though the roots seemed dysplastic and went no place. But yeah. Have you seen cases like this before, and how have you managed them in your practice?
I haven't seen something like this before. I've seen the U-shaped conjoined twins at the end of the spinal cord. But I think you have to manage this basically as a lesion that's attaching to the spinal cord and take out as much as you feel is safe to do. I think the issue is that going forward, you've obviously got to set up for tethering and for some abnormal spine growth over time. And those are the things you're going to have to watch for, following closely, obviously.
That's a really good point. I haven't seen this child in several years now. It's been I don't know what year, Toby, do you
20,
surgeons gave her the pictures.
2016, 17 is when you were, 2017 was the last time you saw them.
That's a good point, Jack. We should probably have the neurosurgeons in Kuwait follow up. We have one of our residents from many years ago who was a Kuwaiti resident who was sponsored by the government to train here, he and his brother. And he went back and he lives in the Taj Mahal of Kuwait. He's been anointed the country's neurosurgeon. He's a very talented guy. So he sees a lot of these children. Hisham Al-Kayad is his name. He's a very talented guy, but so we'll have Hisham follow up.
I would certainly want to follow him at least every year for a while he's growing.
Yeah, good point.
Dr. Walker, how many sets of craniopagus twins have you taken apart? Just to kind of piggyback on your talk that you're going to give tomorrow, how many have you taken apart?
I've done three sets.
Okay, and how are they all doing?
They all have some impairment, but they've all graduated high school. The first set, I think I've got it on my slide for tomorrow. I think the first set are like 39 years old now. The second one was 5 years after the first one. I think the best ones that are neurologically are the most recent set that I did in 96. But a lot of this relates to shared neurological tissue, and you're going to find it different in different situations, obviously.
Right.
Okay, our next patient, switching gears a little bit. This is a child who presented to ER triage with a gunshot wound to the head and abdomen. Was moving everything, but there was active extravasation of brain tissue and hemorrhage through the entry site in the left forehead. There was also right frontoparietal exit wound. Given his intra-abdominal injuries, he was taken immediately for exploratory laparotomy by the pediatric surgery service. Only post-operatively did we get this image. As you can see, the left frontal entry wound and the exit site over here. So bifrontal injury, active extravasation of brain and hemorrhage. An EVD was placed. ICP control was optimized. His coagulopathy was corrected. Was monitored with his ICPs controlled as best as possible for about 2 weeks. The ICPs did improve. He required, again, aggressive ICP control with paralytics and drainage from the EVD. Gradually, the CT actually did show improved edema, and his exam improved. So remarkably, at 3 weeks after the injury, he was localizing and actually intermittently following commands. 4 weeks after the injury, he had an elective angiogram, and this showed a right M4 pseudoaneurysm. This underwent embolization with onyx, and also in this angiogram, 3 pseudoaneurysms were found in the left anterior falcine artery right along the path of the injury. So I'll show those now. A little hard to see the M4 aneurysm. This is the one that, again, underwent onyx embolization. And here you'll see the pseudoaneurysms right there. Additionally, the patient had a CSF leak, was found to have CSF leaking through the nose. Again, the EVD was in place and drainage from the EVD did not alleviate the leak. So he ultimately went to the operating room for an anterior skull-base reconstruction to repair the CSF leak. During the same operation, the decision was made to treat those 3 traumatic pseudoaneurysms with sacrifice of the anterior falcine artery. In the operating room, there was a bicoronal incision for a traditional reconstruction of the anterior skull base and repair of that CSF leak. There was an encephalocele found that was encountered and removed. Ultimately, the artery containing the 3 pseudoaneurysms was identified and sacrificed, and a pericranial graft was used to repair the bony defect and the CSF leak. The patient has done remarkably well. Angiogram showed resolution of the pseudoaneurysms. I'll show that in a moment. And 6 months after the injury, the child is basically intact. So a really remarkable recovery for this child with bifrontal injury from a gunshot wound. Here's the preoperative angiogram, and here's the postoperative angiogram with sacrifice of that artery and treatment of those pseudoaneurysms. So we'd love to hear your experience with gunshot wound trauma in the pediatric population and your thoughts on this case.
Well, I think you managed it the way I would. It was, you never, there's just no good answer for gunshot wounds. This child's fortunate to have done as well, obviously, as he has. When I was in medical school in Memphis, we just saw these every night, you know, all the time. When I got to Utah to intern, they couldn't spell gunshot wound. It just didn't see them. One came in while I was on my ER rotation when I was an intern, and I just was in the room taking care of it, trying to get things stabilized while, and people were saying, "Wow, how'd you know what to do?" So some people have more experience, obviously, than others, but it's something that's I just think so difficult to treat. One of my colleagues once said that when you get a call to the emergency room for a gunshot wound, you want to walk, not run. Just kind of see what happens over the first short time. I noticed that you didn't chase the bone fragments, and it turned out to be good. You know, the experience in Vietnam, I thought, was interesting. What they learned in Vietnam was that when the gunshot wound to the head would come in, the neurosurgeons would take an X-ray, go to the operating room and take out the clot, and try to take out the bone fragments. They would chase them. And then they would go immediately post-op and take a high quality X-ray. And if there were any bone fragments seen on that, they would go back and try to get those bone fragments out, because they learned that if you left a bone fragment, you were going to get an abscess. And that was a different environment, obviously, than some of what we have today. but it's still one of the principles that you worry about if it's reasonable to chase the bone fragments, you want to get them out. In this particular case, I agree that it would have been difficult to just go chasing through there, and it's turned out to be okay. Obviously, the disruption of the skull base was inevitably going to cause you trouble, and you were able to treat the pseudoaneurysms at the same time, and I think that's great.
And have you seen children make this kind of neurologic recovery with a bifrontal injury like this? I think we were all surprised and impressed with how well this patient recovered.
I think it's amazing too. And, you treat these because you're hopeful, and you've seen cases where they make great recoveries. And obviously sometimes they don't do as well as you're hoping, but you need to treat a situation like this, like you did.
I had to step away for a phone call, so I apologize missing the beginning discussion, but I don't know if you mentioned it already, but this kid is actually back in school, having a little bit of difficulties in school. So we're trying to get him plugged in with neuropsych. He actually wasn't local, so he's now back up in the Gainesville area and has transitioned care to them, but he's walking, talking, participating in school and doing pretty remarkable given the injury.
How old is he?
This is Heather McRae, by the way.
How old?
I think he was around 10.
Like
was it
10
10?
or 11, I think. Yeah.
And how far out is he from the injury?
About 6
So
months,
I
I
last
think.
checked in with mom in December, and that was about 3.5 months out from the injury.
Okay, so he's within his first year.
Yeah. So, I mean,
Wow.
I would still expect he may make some additional recovery, especially getting plugged in with services.
That's amazing. And what really you're seeing is that it's an injury to just one hemisphere and to the anterior part of that hemisphere. And that saved him.
I think we were fooled. It looked like it was going to be more of a bihemispheric injury, just because there was swelling in sort of both frontal lobes. And indeed, the gunshot wound came in sort of just to the left of midline and then out right parietal. So it seemed like it was both, but didn't get sort of the midline structures.
Yeah, well,
And he had very difficult to manage ICP initially as well. So also sort of remarkable that he tolerated that as well.
that's just great. It's wonderful that he's made such a great recovery. But I think you went through he took you through the tour of what you see with these, with the pseudoaneurysms, the skull base disruption, the CSF leak, and the things that you have to be aware of and follow up on. So good job.
All right. Our next case, this is a 10-month-old girl, born at 35 weeks, an IVF baby, has multiple congenital abnormalities, including a PFO, PDA, as well as a cleft lip and palate, agenesis of the corpus callosum. Initial referral to neurosurgery was for macrocephaly and, importantly, a lipoma associated with the tethered cord. On exam, the child has had some mild left leg weakness. This has been stable over many months, and the child is able to stand. No UTIs, no obvious urinary issues, and no orthopedic deformities, no foot issues. This is the imaging. As you can see, the lipoma there, no obvious enhancement. So given the numerous comorbidities and other operative comorbidities, most importantly, the cleft lip and palate, also had needed myringotomy tubes. These were active issues that required urgent intervention. And given the patient's stable symptoms and no significant urinary orthopedic problems, the decision was made to delay the untethering until after these other pathologies were managed. So at age 19 months is when the patient ultimately went to the operating room, underwent laminectomy and tethering. And here's the postoperative imaging. So you can see that there. Pathology showed lipoma as expected. Interestingly, though, the pathologist noted some ectopic immature renal tissue. And because of this finding, the patient's been followed with serial MRIs, clinically doing well, ambulating, no UTIs, and again, no lower extremity orthopedic deformities. So curious as to your thoughts, if you ever seen this kind of unusual pathology and kind of how you would manage this patient.
I have seen that unusual pathology. I don't think it changes the management of whether it's a straightforward lipoma or not. Yeah, I think you would still surgically manage the patient the same way. It looks like what happened at surgery was to take that lipoma down to the level of the spinal cord itself and do what was felt to be safe and stop. And that's the appropriate management of the patient at this age, a young one. Obviously, going forward, you have to watch and watch the neurological status as well as watching the spinal status as the patient grows. How old is the patient now?
Surgery was done at 19 months. I don't know how long ago this was. I don't know if anyone else wants to chime in.
I want to say it was 2 years ago. This is Dr. Wang's patient. I want to say it was a year and a half, 2 years ago. Yeah, something like that. Dr. Walker, what is your, with these lipomas and these lipomyelomeningocele, how has your practice changed during your career? How did your practice change during your career with those different schools of thought, such as Dr. Peng, who would say you have to take all of the lipoma off? But what have you kind of, if you could tell your younger self when you started practice what you know now, how would you manage these differently?
I was much more aggressive as a younger surgeon. I don't think any of us had real experience about what this is. When I was a fellow in Toronto, the concept of a tethered cord was brand new. There were neurosurgeons saying, no, it doesn't exist, don't worry about it. There were neurosurgeons saying, this is a new disease, so to speak. So we were just learning about tethered cord and what it might mean. I was more aggressive. I just thought, well, I'm a surgeon and there's trouble there and I'm just going to take it out. And if you compare that to the end of my career, I would have done exactly what you've done here and left some of the spinal cord or some of the lipoma alone. If you're there surgically and you see the plane and you're not worried about it being neural tissue, I would keep going just because it's obvious that you're still safe. You're monitoring the patient at the same time. But I would not be too aggressive with it. So the answer to your question is I'm a much more conservative surgeon with this disease than I was as a younger surgeon. I've been there, I've done that. I've seen the spinal cord, and what Dr. Peng is saying is, I mean, he's able to accomplish that, but most surgeons are not. I'll just put it that way.
Thank you.
Have you ever had a patient who had pathology like this with this ectopic renal tissue go on to develop issues or growing mass on the MRI? Have you ever seen that pathology develop into something worrisome?
I have not. It's always a possibility, I guess, but I have not seen that.
Dr. Walker, can I ask you to talk to the residents with your experience with gallbladder shunts? I know I think you do one there, and that's the only one I've ever seen in my career. So can you explain to the residents, and obviously it's kind of the last hurrah, but I haven't done one here. I haven't seen one done here in the last 10 years since I've been here, but maybe give them perspective from your side about gallbladder shunts, because it's something they read about but they've never seen it. So I'd love to hear you talk to them about that.
I've done 3 of them. So over a 40-year career, that maybe is a perspective of how often you're forced into doing that. All 3 of them have not had to be revised.
Oh, wow.
I don't know what that says, but if you think about it, the shunt emptying into the gallbladder sac, there's a natural pressure within the sac. So probably from a physiological standpoint, you're not over draining like you would be into just the wide open peritoneal cavity or into the vascular system. So it may be that these patients are doing okay because they've stabilized their intracranial environment. They're sort of been traditionally the last resort. Where can we put a shunt now that there's no abdominal space, it's all scarred in, and we've tried the vascular system a couple of times and it doesn't work, or maybe all the vessels are clotted off already. So the downside is that there's at least one case I know of a gallbladder shunt where for some reason the shunt was, I guess it was, I'm lost on the word, but it allowed the retrograde flow. So there was bile that ended up in the ventricle, which was fatal to the patient. The shunt valve was incompetent. I don't know if I've ever seen one that was incompetent, but apparently that's what happened in that particular case. But it's kind of a last resort, and an experience of 3 of them doesn't really tell you much, but it is something that can be done.
Thank you.
And in today's environment, the question is, can you get in there with a scope like the surgeons do, and they can do this without doing a big open procedure? On the other hand, the reason you're doing the gallbladder shunt is because the abdomen's all scarred down, and is the surgeon really able to do this endoscopically? In my particular case, they did a small open procedure and placed the gallbladder shunt.
Do the residents have any questions for Dr. Walker here? We have a couple minutes left. Do you guys have any questions at all for him? All right, well, we can do one more case then, and then we've used up all our time with you, Dr. Walker.
All right, last but not least, this is a 9-year-old boy, right-handed, who presented with intermittent episodes of nausea and vomiting and a progressive headache. worse, progressively worsening, and ultimately was brought to the hospital due to these symptoms. Patient presented sleepy but arousable, had bradycardia and vitals as you see, but otherwise non-focal. Here's the initial imaging on CT, showing this pineal region mass. And here's the initial MRI showing this mixed density enhancing cystic lesion of the pineal region. So initially the patient was taken for an ETV and a biopsy of the lesion in order to obtain tissue diagnosis. Pathology came back as mature teratoma. Based on the pathology, the child underwent chemotherapy. Ultimately, was followed, and a year and a half later was found to have progression of the tumor. So here's the most recent MRI showing in progression of lesion enlargements, so we were curious to get your thoughts on managing this recurrent tumor and what you think should be done.
So I'll just interject there. He did, it came back as a mixed germ cell tumor initially, and then mature teratoma. So he had mature teratoma that grew after the germ cell component was treated. So it was a mix.
I think I would operate on this. I'm just trying to decide how I would approach it. I would probably approach this as from an occipital approach posteriorly, getting into it from the posterior and approaching it to favoring on the side where the lesion is in the ventricle.
So we did an interhemispheric transcallosal, posterior transcallosal type approach because it was coming into that ventricle.
And that's the other approach I was anticipating. I think.
Do you have the post-op images, Mike?
I don't know. I don't think I got those. Yeah, no. Okay. Sorry, I don't have the post-op.
No worries. So this is a gross total resection, but this is an interesting case because the progression, and we don't have all the images here, and I apologize for that, but the progression of this lesion really, it was much smaller. He got chemo, he was okay. It was smaller for some time, and then it kind of grew out of control and fungated in a very short period of time. We were able to achieve a gross total resection with him, and the kid's actually doing great right now. We're following him every 6 months. He also did get radiation as well because of his the germ cell component as well within his tumor, but he's doing great right now. Has some great in the sense of neurologically he's intact, but obviously is having some difficulties in school and needs some extra time in school to finish homework and tests and these sorts of things. And we follow them with neuropsychology from that perspective. But
you came interhemispheric and transcallosal?
Yes, sir.
At what level did you do that?
We came, it was more right here where it's entering up into, so mid corpus callosum, more where it was fungating right into the corpus callosum at that level.
And so when you approached the corpus callosum, could you see the tumor? Was it coming up through the corpus?
It had come through.
So that gave you a little bit of safety in terms of going in directly.
Yeah.
Yeah, these lesions are usually very distinct once you get there.
It was hard like concrete, to be honest with you. It was impressive. We had to use a very aggressive like sonopet tip once we were able to locate the internal cerebral veins, and it was like concrete in there. So it was an impressive.
Amazing how hard they can get.
Yeah.
I would have been curious what I would have seen if I'd have gone with the posterior occipital approach. I still think I would have seen the stuff in the ventricle pretty easily from back there, but
Yeah. My only concern was I felt like that was a longer reach than coming in from the top.
it would have been a very long reach.
Yeah.
That's but I think you're right. You were able to get through the corpus without causing more damage to the corpus, really, which was a good thing.
Yeah. Well, I think that's all the time we have with you, Dr. Walker. It was very nice to see you. Thank you for spending your very early morning with us. And thank you for, honoring Dr. Bhatia's memory with us. It's really nice to see you.
Well, thank you. It's nice to be here, and I appreciate the residents showing me the cases.
Thanks, Dr. Walker.
Thank
Thanks,
you.
Michael.
Great. Well, have a great rest of the day, Dr. Walker.
Thank you.